I'm Dr. Janet Pope. I'm a professor of medicine and division head in rheumatology. And I've been running our Scleroderma program really since I came on staff. I'm in London, Ontario, so I don't have a British accent. I'm from Canada. I'm on the Scleroderma Foundation Medical Advisory Board, and so I feel it's very important that I come to these meetings and try to share with colleagues and patients, because on either side of the border, the problems with scleroderma are very similar. I'm so our university is called the University of Western Ontario, and my hospital is St. Joseph's Healthcare, or St. Joseph's Hospital. So I will ask questions along the way, and if you're not comfortable, some of them are kind of voting questions, just don't answer, it's okay. There's no right answer on these. These are some of my disclosures for systemic sclerosis consulting and for other consulting that I do. So I'd like to have us become familiar with the 15% rule and really why we developed it and published it. And the 15% rule will help clinicians, patients, even the primary care physician who might be referring onward their patients, other subspecialists, rheumatologists, gastroenterologists, pulmonologists, cardiologists, etc., to understand how common things are so that they can be more holistic when they see a patient with scleroderma, or at least understand, oh, that symptom, that's not so rare, maybe we need to treat it or investigate it or send you to someone that knows about it. And really to understand then what organs are involved, what should be screened for. So some of this will be a repeat of other lectures, because I think that's helpful for you to, have it come home in your brain more than once. And to update you on some knowledge of emerging treatment in scleroderma. And when I say scleroderma, I'm talking here about systemic sclerosis. So I'm not talking about linear or non-systemic scleroderma like morphea. So we're talking about systemic sclerosis, but from here on in, I'll call it scleroderma. So pretty much everyone has Raynaud's. So again, if you're not comfortable, don't do it, but put up your hand if you have Raynaud's. So almost everyone with scleroderma in the room has Raynaud's phenomena. And Raynaud's is really common in the general population. It's about 1 to 3%. I'm in Canada where it's colder, so it's about 3% of our population. So most people with Raynaud's don't have scleroderma, but if you have scleroderma, it's highly unusual not to have Raynaud's. And you can see here this fingertip going white, and it's well demarcated, and you see the other fingertip here, that's blue, and if you're really smart, you see some tuft resorption and a little ulcer that's healed up there. And then there's also common features like the dilated capillaries we see at the nail bed. And you probably wouldn't notice them, but sometimes if you're putting nail polish on, you go, oh, on my cuticle, it looks like little red pen lines. That's the vascular change in scleroderma. So again, not everyone with scleroderma has this, but if you don't have scleroderma, it's unlikely you would have this with your primary Raynaud's. And Raynaud's is that spasm of the blood vessels, fingers or toes, nose, ears, tongue sometimes, going white, blue, and red, or at least 2 of those colors in the cold. And then fingertip ulcers. So again, if you're not shy about it, put up your hand if you've ever had a finger ulcer. So not quite as many as those with Raynaud's, but nearly as many. So finger ulcers are very common at any stage of scleroderma, from early to late. We used to think it was a late complication of damage in the bad blood vessels, but it occurs in about 15% of patients, which we'll talk about. And then the tight skin, sclerodactyly, can be tight where the skin eventually softens, but the fingers don't move, or it can be tight with the skin and the tendons, or it can be quite puffy and inflamed. So these are some of the different changes of skin in your hands. You're going to say, what's this got to do with 15%? We're getting there. Puffy fingers often early on, and this patient has these swollen-looking fingers. The patient also has inflammatory arthritis, and we'll talk about how common that is. So you see a big swollen knuckle here, and the puffy fingers, so rings don't fit. You look like you go, oh, my hands, it looks like I have fluid retention. Sometimes stiff and painful, sometimes not painful. And then the red dots, the telangiectasia. So you can see them on my patient here on her lips. My patient here has them on her face, hands, arms, tongue, and you can see one here on the finger, so they're often on the fingers as well, and you can see a chunk of calcinosis here, that's the white exuding out. So the 15% rule is not going to encompass these things because we couldn't find enough data from the published literature to say how common it is, but I can tell you right now, calcinosis is probably 8 to 30% of patients, depending on how you look. Telangiectasia would be at least 75% of our people with scleroderma or more. And scleroderma is really complicated, and that's why you're here learning about it, and it's very complicated for the doctors and healthcare providers involved in your care. So there's autoimmunity, so making that anti-nuclear antibody, the vasculopathy, so the red, white, and blue hands, the Raynauds, the dilated capillaries that I showed you, and fibrosis or scarring. So this is obliterating or scarring up a blood vessel. That could be in the pulmonary artery, that could be a digital artery, so finger artery, pulmonary artery is in the lungs, and the scarring or the laying down of collagen, which is the fibrosis. So knowing how complicated the history, the physical, and all these features within internal organs are, and knowing that this is a rare disease, it's at most 2 in 10,000. So it's a rare disease. We came up with this rule to really help educate the trainees, but educate our colleagues as well. And as you all know, scleroderma affects so much of your physical function, your personal life, mental health, social life, organ involvement, mouth involvement with dry eyes, dry mouth, decreased oral openings, so dental caries, affecting work, breathing, the skin can be itchy, your GI tract, your Raynauds, more GI things, all these things, fatigue and pain. So again, it is just so all-encompassing that it helps, I think, to give rules. A lot of medical students learn by rules. They memorize things by rules. So we asked our colleagues, how common are these problems? So Raynaud's nearly universal. 15% rule doesn't work. It's about 95 to 98% of people with scleroderma have Raynaud's. So if we think you have scleroderma and you don't have Raynaud's, we think twice, wow, is it morphea or something else? GI involvement, put your hand up if you have problems swallowing or acid reflux. So again, almost everyone that said they have systemic sclerosis, scleroderma, has GI involvement. So the rule doesn't work there. About 80% of our patients have significant acid reflux. General population, probably 5 to 10% have significant acid reflux. And that's your swallowing tube, esophagus, doesn't contract right. So instead of the coordinated peristalsis or contractions, it's discoordinated and not tight contractions. And the bottom of your swallowing tube is inappropriately opened, so you get reflux coming from the stomach upward. So for acid reflux and the discoordination and or the swallowing issues with acid coming up and inflaming or scarring because of the acid in the swallowing tube, you can get dysphagia, so problem swallowing. So it could be dysmotility or narrowing because you have all the inflammation from the acid reflux occurring over often months or years, and so dysphagia or problems swallowing. Classic is food sticking right behind your breastbone. And that's, again, at least 70 to 80% of our patients. So this 15% rule doesn't apply here, but it actually applies to all these things and more. So interstitial lung disease or pulmonary fibrosis occurs in 1 in 3 of our diffuse and 1 in 4 of our limited patients, but about 15% have clinically relevant interstitial lung disease, stuff that we'll investigate and treat and follow carefully. Pulmonary arterial hypertension, PAH, occurs in 12 to 15% of our patients. And it's usually, well, it is today diagnosed by right heart catheterization, but it's usually screened for by the ultrasound of your heart, the echocardiogram, and sometimes by the breathing test as well, looking for a low gas exchange, a low diffusing capacity. So it's about 15% of our patients, and those with interstitial lung disease, it's 15% of them have pulmonary arterial hypertension as well. Finger ulcers, so the 15% rule on your fingertip ulcers, a lot of people put your hands up for that. It's on any day, 15% of our patients walking into the clinic for a follow-up will have a finger ulcer. Not always at the tip, but somewhere. Some of you have had ulcers where your fingers bend. Some have had calcium lumps. Some have had the sores. Some have had where it doesn't look so bad, but it feels super deep inside and can scar and leave a pit. On any day, 15% of our patients have finger ulcers, and 15% of finger ulcers are complicated, needing antibiotics for osteomyelitis, giant ulcers that you need to be admitted for, sometimes amputating, so not everyone will need an amputation by any means, but 15% of finger ulcers are complicated. Kidney crisis, has anyone in the room had scleroderma renal crisis or kidney crisis? So no hands here. This is a now rare complication, but in early diffuse patients, so at the beginning, if you have lots of skin involvement, it's 15% of our patients with early diffuse have scleroderma renal crisis or kidney involvement like that with sudden high blood pressure. But overall, in all of scleroderma patients, if you just cross-sectionally look, it's about 3% of our patients because some are no longer early, so not at risk. Some are not more limited than diffuse. The subset with less skin involvement gets less kidney crisis. And because some of our patients, unfortunately, with kidney crisis don't hang around a long time. Put up your hand if you have inflammatory arthritis, inflammation of joints. So again, same amount of hands almost going up, but not the same people. 15% of our patients have inflammatory arthritis with their scleroderma. Can you put up your hands if you have severe dry eyes and or dry mouth? 15% of our patients have Sjogren's or Sika. Sjogren's is the guy's name, another autoimmune disease that is lymphocytic infiltration, autoimmune, and the glands that produce secretions, so your tears and your saliva. So some will have the overlap with Sjogren's, and others will have scarring of their glands without any other autoantibodies from Sjogren's syndrome, so 15% of our patients. Put up your hand if you've had muscle involvement, so myositis or myopathy. So a few less hands, about 10 to 15% of our patients with scleroderma will have muscle involvement. Some inflammation. Inflammation is actually treatable, we think. Overlap with polymyositis or dermatomyositis. And some with, again, scarring, collagen laying down in the tissues of the muscles. The latter problem is not so treatable because we can't undo that wasting of muscles from the scarring. So when we looked into the 15% rule, and then I'm going over it to help reiterate, it doesn't work for Raynaud's, nearly everyone. Doesn't work for acid reflux and swallowing issues, but half of 15% of our patients have severe gut involvement, needing surgery, repeated dilatations on their swallowing tube, needing parenteral nutrition, having severe low bowel involvement like incontinence. So that's about half of 15%, so almost works. So to reiterate, half our patients ever have had a finger ulcer, but on any day, 15% of our patients have a finger ulcer, a digital or finger ulcer. 15% of those are complicated. 15% have pulmonary arterial hypertension. 10 to 15% of the diffuse early have kidney crisis. Lots of people have scarring on the lungs, but in 15%, it's a moderate restrictive defect or worse. 15% of myopathy or myositis, that's the muscle involvement. 15% have the autoimmune or scarred up glands with dry eyes, dry mouth. So some of our rules when I talk about what we do about these things, we have to identify them. So we think of treating scleroderma by overall, can I change the trajectory of your disease? And we'll call that disease modification. We're used to that concept in lupus or in rheumatoid arthritis where we give disease modifying drugs. In scleroderma, a disease modifying drug would be probably an immune suppressive to try to soften skin, decrease organ involvement, lessen organ involvement. But also we have targeted organ treatment. So for my swallowing tube, immune suppression doesn't work, so we have pro-motility drugs, we have anti-reflux drugs, so antacids, proton pump inhibitors, drugs that improve contraction. But for some organs, we do immune suppression. So in the lungs, you might be on an immune suppressive drug, mycophenolate mofetil, also called Cellcept, or Myfortic, cyclophosphamide, some of the interstitial lung disease drugs that are more novel, that are in trials, things like that. And we also, when we're treating organs, if we're immune suppressing, we think of induction and maintenance. So if I'm treating the muscle involvement, I might need high doses of corticosteroids, prednisone steroids, and an immune suppressive drug, and eventually get those steroids off. But if it's all scarred up muscle, that's not how we treat it. So if it's inflammation. The other concept is so induction and maintenance, overall or organ-specific treatment, then also treat what's treatable. So we tend to screen for organ system that have treatment, that if we give treatment early, we change the trajectory. So I wouldn't screen you for muscle involvement unless if you said you were weak, or if I was doing tests because you say lost weight, or I've done just a random blood test and found your muscle enzyme is elevated, then I would maybe do EMG, electrode studies, a biopsy, things like that. So I wouldn't screen without history or physical exam findings or just an easy lab that might be done. But for your lungs early on, and for your heart and lungs, the pulmonary arteries, we are probably going to screen that fairly regularly, and you'll hear different approaches at different sites, but in general, you're trying to detect something before it's more relevant to the patient to dampen down that inflammation or reduce the scarring. Always, I tell the trainees and everyone else, treat what's treatable. So sometimes I'll say, okay, tell me what else is going on. My pain, okay. What's your pain from? Okay, that's treatable. You've got this problem. Oh, I can't help that so much. You're doing all the right things. I don't have further treatment. What else is going on? Inflammatory arthritis, swollen joints? Okay, I can treat that. So treat what's treatable is always good, because you might have many hands were put up for all sorts of different organ involvement. And then what's important for your doctors is to follow guidelines where guidelines exist. So looking at the guidelines that are out there and making sure we're up to date on that. So there's two main guidelines. So the American College of Rheumatology and the Scleroderma Foundation at this point in time do not have guidelines, but we tend to use the recommendations or guidelines from other societies. So the European group, the European League Against Rheumatism, called EULAR, their main body of research and advocacy and education in scleroderma is EUSTAR, European Scleroderma Trials and Research Group. And so they've made guidelines. They have guidelines on Raynaud's, digital ulcer management, pulmonary arterial hypertension screening and management, detection and treatment of lung disease, skin involvement, and how to manage scleroderma renal crisis and the GI tract. They also had future research questions that should be answered. Then the British Society of Rheumatology and their allied health professionals have guidelines that fully overlap in here, and you think they better overlap. They're looking at the same literature. You wouldn't want way different guidelines. But they also have guidelines on general management of scleroderma, saying if you have serious scleroderma involvement, significant organ involvement, significant skin involvement, you should have the right to go to a specialty center. Now, this is from Britain, UK, where there's global healthcare there and National Health Service there, but they make comments like, you will do better if you have a subspecialty section. So if you have serious pulmonary arterial hypertension or any pulmonary arterial hypertension that's proven, you should have an expert treating you. And that expert could be different at different sites. It might be a pulmonologist at one site and a cardiologist at another. But because this is a complication that will kill you, it's a lethal complication, and because there's many treatments that will prolong your life, you should have the right to go to a specialty center. They also have guidelines in non-pharmacologic management, so hand function, treatment of pain that's not just taking meds, even though meds might be effective for people, physical modalities like range of motion and splinting to keep your hands going. And the British guidelines also talk about cardiac, so heart involvement. The European ones don't. They talk about calcinosis, which is very annoying, and I'll tell you right now, we don't know how to treat it very effectively. And musculoskeletal involvement, myopathy, inflammatory arthritis, contractures. So these are really good guidelines, and the general rheumatologist, the general pulmonologist doesn't really read these regularly. But if they have a patient coming, they should be aware of at least the 15% rule because it helps the organs, or they should be aware of guidelines. So I'm now going to talk about some of these areas that have 15% or more involvement. So for the lung, the scarring is usually at the bases, and some inflammation comes before scarring. We believe inflammation is reversible. If you have scarring that we call it honeycombing, it looks like a honeycomb or it looks like Swiss cheese holes, we can't make the holes fill in. So honeycombing or bad scarring is not reversible. But the chance of progression of your lung disease is highest if you already have scarring, because that means that your inflammation leads to scarring, which leads to more damage. And that's true with anything. Damage is a high risk of more damage. That's true in rheumatoid arthritis. If you have damage in your joints, it's the highest chance of more damage down the road. So we'll talk about that. But interstitial lung disease is 1 in 3 of our diffuse, 1 in 4 of our limited, but in 1 in 6, 15% of people, it's clinically relevant. And I'm also going to talk about pulmonary arterial hypertension. So these are big pulmonary arteries because all the branches of the tree have been pruned inappropriately. They're cut off, and therefore it's high pressures to pump the pulmonary arteries. So here's an example of screening that helps us. So these are echocardiogram screening programs. So there's also one in the US that's been published, the REVEAL registry, but the French registry and the Australian registry were the first two to show that if they screen, they pick up patients earlier. The diagnosis of pulmonary arterial hypertension, though, is only made by right heart catheterization. The ultrasound of your heart, the echo, the Doppler on your heart with the gel is a screening test. But if they screen, they find 15% of patients, the rule exists, have pulmonary arterial hypertension. And if they screen, they pick up the patients earlier. So they have a better walk distance over 6 minutes. They have lower pulmonary vascular resistance, the pressures in the lung, and they're more apt to be less symptomatic. So screening detects our patients earlier. And as I say, the US study REVEAL has shown that as well. And this is just an example of how we did the 15% rule. We basically looked at all the registries that had 100 or more patients from 1966 onward, but most of them were publications from the 80s, 90s, and beyond. And then we looked at these cross-sectional or moving forward registries or cohorts or a series of patients, and we looked in right here, you can see 15% of patients, that's the 0.15 there, have pulmonary arterial hypertension. But in registries, it can be as low as about 8 to 12% and even as high as 20-some%. But it's about 15% of our patients. So 1 in 6 of our scleroderma patients will get this. Who gets it? Older age of onset, older age, so longer disease duration. So age is a risk factor. And often long-term survivors. Other things have not done them in, and this is something that occurs with longer disease duration and age. But the limited might be at higher risk than diffuse, but I say might be because I'm not so sure if you adjust for disease duration, I'm not so sure that that's true. So in other words, everybody pretty much with systemic sclerosis, scleroderma is at risk, so we have to screen patients. So we think about it in long-standing limited, older age or older age of onset, but it can occur in the diffuse subset, the ones with more skin involvement at any age or stage. And in the diffuse, it might be secondary to really bad lungs. So hypoxia or poor oxygen in the lungs, your body says, I gotta pump with higher pressures to get things going, to get oxygenation going. And some of the markers are, if you do the breathing tests and you're getting screened for that, the low gas exchange, which we call the diffusing capacity of carbon monoxide, DLCO, is what we use on the breathing test. Some people will do a blood test. There's a whole algorithm of screening as well. And interestingly, uric acid, which goes elevated in gout patients. Uric acid might be a screen as well, saying my heart's in trouble, just like high uric acid might also be a screen for a bad heart pump. So that's an investigational one, so I just put it there as in red. And we have different treatment, and some of you have probably gone to some of the treatment lectures. So the treatment is use drugs together in general, either initially or add over time, and use drugs from different classes. And almost all the classes can be combined except for riosequat with the PDE5 inhibitors. PDE5 inhibitors are your sildenafil or Viagra, Revatio, Tadalafil, those sorts of drugs. You don't combine riosequat with that, but otherwise endothelin receptor inhibitors, prostacyclins to open up blood vessels, and probably these help in remodeling to a better way, that the blood vessel is no longer obliterated and narrowed, but it's not just opened a bit, but it remodels to get more blood through. So it actually helps some of the damage over time. And we have many treatment options. So as I say, the trends are treating earlier, so screen and treat functional class 2, which is slight shortness of breath. So we don't have to wait for severe shortness of breath or shortness of breath with all activities or even at rest. And usually adding versus switching, having a target in mind, just like if you have cholesterol, your doctor has a target in mind of your cholesterol number. We have a target in mind here, but no one agrees on the target. Should it be your walk time better, your echo better, your breathing better, all the above, biomarker being better? We're not sure of the target, but virtually every center will have a target in mind, and they keep trying to get you to that target. So a question that we've had is, should we screen for interstitial lung disease? So how common is clinically relevant interstitial lung disease and scleroderma? Shout it out. 15%. You're learning. You're better than the med students. They kind of look at me like cross-eyed. So 15%. So again, 1 in 6 people are 15%, pretty common. So we don't agree on who to screen, but early on in your disease, you get screened more often. If you already have changes, you get screened more often. If you have a low diffusing capacity on one of your screens, you'll be screened more often, sometimes for both the echocardiogram for the pulmonary arteries and the breathing. It's more relevant in the diffuse. The diffuse have more skin involvement, also in general have more internal organ involvement, but limited or diffuse can get it. It's more common with one of our autoantibodies, so it's part of the extractable nuclear antigen called SCL70 or TOPO1, topoisomerase 1, and every lab does that, so that's a common test that's done at the time of your diagnosis. Oh, your ANA is positive, and these features in the ENA, it's called, are positive or negative. So those people are at higher risk. If you already have scarring, those people are screened more often. And why should we screen? Because people with worse disease do worse. What a surprise. People have a higher mortality, higher chance of dying if they have bad lung disease. There is potential treatment, so there's potential for reversibility, not 100% reversible, but stability or slowing down progression. So our target might vary depending on where you are in your trajectory. And I'll say it's somewhat treatable. Some of you have seen the lung lectures here, or you know people with interstitial lung disease, the 1 in 6 with scleroderma, and there's various treatments. So we can screen because it's common, 1 in 6, and justifying treatment, experts told us when we did research on this, moderate to severe lung disease should be treated. Evidence of evidence of recent deterioration, so breathing tests are worsening or the patient's more short of breath. Short symptom duration, so early in disease, you're more apt to get lung disease than if you've never had it, than to get it at 6 years out, as a for instance. Having that positive antibody I told you, the SCL70. Worsening on imaging, like if you auscultate, listen, and do a chest x-ray, if we see changes. On the plain chest x-ray, we usually do a high-resolution CAT scan, CT scan of your lungs to look. The experts did not say shortness of breath, but that would be someone I would treat if you're short of breath, and I think it's your interstitial lung disease, and I can't find another cause. I would probably treat you, even if you only had mild changes on the breathing test, but experts didn't really agree on that one. I thought it was kind of good. And then we don't usually do a biopsy. The only time you would normally get a biopsy is if we don't know what's going on. Oh my goodness, do you have a lung infection because of immune suppressed you and you're worse, or do you actually have worsening interstitial lung disease? But there's a lot of studies showing that the biopsy otherwise doesn't tell us what to do for you for your lung disease, that it doesn't give the answers. And again, we have induction, get them better. Maintenance, get them better on less aggressive, less dose of drugs. So induction used to be cyclophosphamide. Now it's more mycophenolate mofetil, MMF, or Cellcept. And sometimes it's azathioprine. And maintenance is often mycophenolate mofetil. So in this case, you could do induction and maintenance with the same drug, but you might lower the dose over time. Less immune suppression, less chance of low counts, less cost if I lower the dose over time if you're doing well. But if we stop treatment altogether, you have a good chance in 1 year of rebounding to be bad again. So we usually need long-term treatment. Do I need to treat you for the next 20 years? I don't know. But I do need to treat you in the near future and ongoing for a while. We don't know how long. But stopping treatment early after a year will rebound patients, at least shown in one trial. So we also have some treatment not yet approved in the US. So tocilizumab or Actemra is approved in rheumatoid arthritis. You just got approval in the US for a different disease, temporal arteritis, and might eventually be, will likely be approved after the results of the second trial are out, which is all, the trial's all enrolled but not done or analyzed yet. And what this shows is that these are people with active early diffuse scleroderma, so skin involvement, and they looked at the lung parameters, and you want to be on the no decline side. That shifting this way is better than that way. And the blue is the active treatment with Actemra or tocilizumab, anti-IL-6, and the green is fake, the placebo. So you'd rather go this way to no deterioration than that way to more deterioration. So it actually showed some improvement in lung disease, even though probably only 1 in 6, 15%, a clinically relevant lung disease. So the second trial is enrolled, not completed yet, so we don't have the answers. And it takes 2 randomized controlled trials to get a drug approved by FDA for an indication. So you might see that coming. This is a single-site randomized controlled trial of rituximab for interstitial lung disease. We are talking about 8 people on active treatment, 10 on fake, and then the fakes got off of treatment after year 2. So in 2 years, the placebo, so they started with the same lung function, 100% predicted, 80 to 120% predicted, in fact, is normal. So the forced vital capacity was 9% better in rituximab, highly clinically relevant. The gas exchange, diffusing capacity of carbon monoxide was better on the rituximab, and the skin score improved far more. So the skin score was lower at the end, which means improvement. And all these things are strongly significant. Is this drug approved at all for scleroderma? No. Is it approved for rheumatoid arthritis? Yes. Is it approved for lymphoma, non-Hodgkin's lymphoma? Yes. But it's not approved in scleroderma. When do I use it? I use it when mycophenolate mofetil, that's your Cellcept or MMF, fails. Cyclophosphamide is not working. I will add rituximab. 100% off-label, this is one wee little study that I'm basing my data on, plus some case reports. And I have to beg the insurance providers to give me the drug because it's not approved for this indication. There is a trial, NIH trial, actually looking at pulmonary arterial hypertension and scleroderma with this drug. So we might learn more about it in a different part. This is the lung study, so this is improvement if you have cyclophosphamide, they improve. You stop cyclophosphamide, they worsen. You give them fake, they get worse. And you see when you stop drug after a year of cyclophosphamide, this improves, you get bad again. So cyclophosphamide can help skin and lungs, but it is more toxic than Cellcept. And this is the Cellcept or mycophenolate mofetil, and some of you know it as MMF, high dose, 2 years of Cellcept or MMF at high dose, or 1 year of cyclophosphamide and then a fake. And you can see you improve your vital capacity, you improve your Dyspnea change, although it's a little bit better on cyclophosphamide. Skin improves more, double the amount of improvement. So that's a little bit of improvement, 3 points on the skin score. 6 points is more clinically relevant. So cyclophosphamide improves skin more, even though it got 1 year of treatment, not 2. But cyclophosphamide had more deaths. And we don't know fully yet if the deaths were on the fake when they worsened or if it was on the active treatment. But cyclophosphamide, virtually everyone would agree, is not quite as safe as Cellcept, but either could help your lungs, and cyclophosphamide actually helps the skin a bit better. None of these are the magic bullet, but they have proven data to help our patients, and not everyone responds to everything. So there's other drugs under investigation that are approved for the idiopathic pulmonary fibrosis. They're patients that only have scarring on their lungs. They don't have a systemic disease, IPF. And these are drugs that are being looked into, already enrolling. And the Scleroderma Lung Study 3 will be one of these, pirfenidone with mycophenolate mofetil or mycophenolate mofetil alone. So the interstitial lung disease treatments are here, usually not steroids, and experimental treatments over on this side, and more to come. And it's important to note that if you have bad swallowing and you have lung disease, the biggest predictor of progression in the next 3 years of worsening your lungs more, so progression of your lung disease, is aspiration. So if you are choking a lot, waking up with acid reflux, so acid in your mouth or food contents, and or if you've needed a dilatation to stretch your swallowing tube, it is really, really important, if you have interstitial lung disease, that we try to prevent further aspiration. Stomach contents or acid that goes into the lungs will progress lung disease. It's bad for your lungs. So and that's actually true with other interstitial lung disease, not just in scleroderma, but our scleroderma folks have so much acid reflux as it is. So you have to raise the head of your bed, don't eat after supper time, take pro-motility agents, talk. The lung doctor usually gets the GI doctor or your scleroderma expert involved in not having aspiration. So I put this on. Fancy stats doesn't matter, but that's why I put it on, to tell you aspiration will predict progression. So what about finger ulcers? So treatment of Raynaud's, or hands going white, blue, red in the cold, various things, calcium channel blockers like nifedipine, Procardia, Adalat, it's called different names. That's the most common. Topical, oral. We're far more apt in severe Raynaud's or with bad finger ulcers to use the drugs like Viagra, sildenafil, tadalafil, Ravadio, so the PDE5 inhibitors. Sometimes we'll use prostacyclins like epoprostenol or iloprost. So those are some of the things that we use. So for finger ulcers, instead of induction and maintenance, we think of treatment, healing, and prevention. So calcium channel blockers can help prevent ulcers. A wee bit of data. Iloprost, which is not easy to get in the US, some data, but sildenafil or tadalafil have some data as well. Prevention, bosentan, which is an endothelin receptor blocker, not approved in the US in prevention, but approved in Europe for prevention. But it's about 30,000 US a year. It's generic now, but still expensive. But good old cholesterol-lowering drug that you know as Lipitor, atorvastatin. One small study says that high-dose cholesterol-lowering drug, Lipitor or atorvastatin, will prevent new ulcers. So this is something I tell the trainees, I tell the colleagues, and I tell my patients, is it's inexpensive, it's good for your heart anyway. Even if your cholesterol is okay, there's more hardening of the arteries in scleroderma, but I'm doing it to prevent new ulcers. It's inexpensive, usually well tolerated. And probably the medicines that open up blood vessels here will give healing and prevention, but these prevention drugs here do not heal. They probably prevent by, making less bad cytokine soup in your digital blood vessels. So
Can you go back a minute?
Yeah.
Down at the bottom it says negative trials for
Macitentan.
Opsumate. PAH patients take that, so then it's a catch-22.
Right, so if you have PAH, Opsumit or Macitentan can prolong your life, prevent hospitalization, improve how you're doing. But in 2 large trials, of which I and others are authors on, it did not show prevention of finger ulcers, whereas bosentan did. But pulmonary arterial hypertension is a lethal complication. So if you're on it, you might, for your pulmonary hypertension, you might be using then a cholesterol drug to prevent, maybe baby dose aspirin, which has no data but makes me feel better, might make you feel better, might not. But you might use nifedipine, which is your Procardia, we call it Adalat, or you might be using your sildenafil, which is Ravadio. Ravadio and tadalafil are both, Adcirca, are approved in pulmonary arterial hypertension. So I think always treat what's treatable, but there's an order effect. If I can prolong your life in one thing and just prevent ulcers, not just, they're important, the ulcers, I'm still going to go for prolonging life and then figure out the ulcers as well. So you gotta, it's a very astute question though, but Macitentan unfortunately doesn't work because it could be a 2-for-1. That it could help 2 things. So these are what the European recommendations are. So Sjogren's, dry eyes, dry mouth. So who has that autoimmune or that bad dry eyes, dry mouth in the room? So not as many people. So again, up to 15% longer standing disease or people with an overlap of Sjogren's. Basically, the dry eyes, artificial tears, not things for allergies. So you're not using allergies like Visine. You're not using that treatment. You're using artificial natural tears. Sometimes other tears that have hyaluronic acid. So that's like having gel in your eyes, that not to make it gel that you can't see, but that lubricate the eyes. For dry mouth, there's some drugs that make secretions. There's products you can use like mouthwash biotin that is not, it's not alcohol based, and going to the dentist frequently. Already it's hard with scleroderma. Your hands don't work as well. Your mouth doesn't open as well if you have dryness as well and acid reflux. And some of our meds, your teeth can be a mess because it's difficult. So seeing the dentist more often is important too. And these are some of the tips. I won't go over it, but it's in your handout because not many of you have that complication. Arthritis and scleroderma, 12%, but the range is up to 16%. So joint pain, tendon pain in scleroderma is at least 1 in 3. Inflammatory arthritis, so is 1 in 6, and half those people need disease-modifying drugs. Methotrexate, azathioprine, mycophenolate, mofetil. We start sounding like the same drugs over and over sometimes. Hydroxychloroquine, low-dose steroids, lots of different things to use for treatment. So these are some of the treatments here. And then myositis, the muscle involvement. Inflammatory myositis, not so common. That's an overlap with dermatomyositis or polymyositis. But you can see again here, 15%. So 13% overall have it from all these studies that we looked at. And the overlaps, treat what's treatable. So I treat the inflammation if it's present, but I have to investigate to know if you have inflammation. So I might do on the EMG, the nerve conduction studies. I'll do a power exam. I'll do a blood test for your CK. I might do a muscle biopsy or an MRI to help figure it out, an MRI of the muscle. So the 15% rule really goes, it also involves heart involvement, conduction problems, heart pump problems, scarring of heart, fluid around heart, up to 15% of our patients. Clinically relevant heart involvement, not right heart from pulmonary hypertension, but overall heart involvement is less than 15% of my patients. But when you combine the various things, heart arrhythmia, fluid around the heart pump problems, diastolic dysfunction, blood pressure issues from your heart, not from regular people, which is hard to tell sometimes. Is it idiopathic hypertension like your friend, or is it from your scleroderma? That's up to 15% of people. So I think this gives you a nice overview of really looking from top to bottom or throughout the organs. And as I say, we published on this because I wanted a training to be published, but we published really because it helps us understand for the, especially the trainees and the allied health professionals and the doctors involved in your care, how common these things are. So many organs are common, 1 in 6 of each organ is the commonality, or the 15%. Some we screen for, and things may indeed be treatable. And I think there's a hope message that research is finally catching up to this serious disease. I gave you some of the trial data in the talk, that there's lots of good help. I couldn't do this without the trainees that helped me, without the organizations that helped to pay for things, and I'd like to thank you very much. And we do have time for questions if you'd like to stay. Thank you. Question?
You were talking about GI issues and nobody seems to address this, and I'm to the point now where I don't know what to do because I've been in the hospital twice because of this. I have AVMs, and they decide...
They bleed, yeah. So GI issues, and in this case, just like the telangiectasia, the red dots you can get the red dots, or the blood vessel arterial venous malformation. So it's like a tangled blood vessel net, and those blood vessels, you put food on them, which is abrading it, or you have acid in your stomach or in your swallowing tube or elsewhere, and it just is friable and bleeds. So acid just makes it break down more easily and bleed. So basically, if it's in your stomach, it's also called GAVE, gastric antral vascular ectasia, or also known as watermelon stomach, because it looks like these blood vessel tangled webs are in lines like on the outside of a watermelon. So that is treated with repeated laser, and they have to keep going, and the GI doctor has to be aware that one treatment is insufficient. You usually present with low energy, low blood, iron deficiency anemia, so low hemoglobin anemia, because you're leaking blood all the time, and it has to be treated with laser. If you have AVNs in the small bowel or the large bowel, it's harder to treat, but in the stomach, that's how they treat it, with laser. If you have one AVM, one area of a tangle, you probably have more. So if you're bleeding in one and they zap it somehow or embolize it, sometimes they go through an artery and embolize it, but that's only the big ones. They can go that way, the radiologist or the interventional gastroenterologist. But if you have one, you probably have more. That's the problem. Yeah, so that's what, you know, you just say, if I have one, I probably have more. I heard it. I'm not a gastroenterologist, but it's my experience. One means more. Just like if you have one dot on your face, you probably have more, and they increase over time. I don't know that they increase over time in your stomach, but I wouldn't be surprised. Or in your GI tract, I should say. Yep.
I've got a couple unrelated questions. One, you mentioned a skin score. How is that measured?
Right, so the skin score, it's called the Modified Rodnan Skin Score, or MRSS, little m, capital RSS, or their capitals. So the Modified Rodnan Skin Score, we look at 0 to 3 on fingers, both sides, dorsum of the hand, lower arm, upper arm, face and neck to the clavicles, anterior chest, tummy or abdomen, upper legs, legs from knees to ankles on both sides, and the feet. So the little toes don't get separate, whereas the fingers do. And you add it up, and we can call it hardly any, mild, moderate, or severe, severely high skin score. And again, many rheumatologists, immunologists are not going to record the score. At the Scleroderma expert sites, they probably are doing it, and they follow it over time. So it's something that not every well, and the other specialists aren't even going to look at your skin, let's face it. So the gastroenterologist is going to look in your gut and help you out, and the lung doctor is going to help the lungs, so pulmonologist, respirologist, and the heart person is going to do the right heart cath or treat your heart failure or what have you. So it's mostly the general internist or dermatologist rarely, but the rheumatologist mostly in North America that would be doing your skin score, and usually only at the expert centers. Great, and you have another question?
Yeah, I have another question about protein in the urine. Is that an indicator of potential kidney?
Right, so protein in the urine. Protein in the urine's a tough one because I don't run, I don't exercise very much, but you know, it's hot here, even though I've been drinking a lot, I've been all over the place walking around, getting my 10,000 steps in. I could have a trace of protein in my urine as a totally normal, healthy person. So protein in the urine a little bit is common in all of us. You exercise, you might pee out a bit of protein. It's the amount of protein and what we think it's associated with. But in general, scleroderma kidney crisis is not associated with protein in the urine, and in general, I can't get a 15% rule other than that early diffuse, that 3% of overall, but 15% of early diffuse have kidney crisis. That might have a little bit of protein, but not much. It's not the main feature. So protein in the urine, if someone has it, I'd say let's look for other reasons, but let's quantify it. Let's repeat the test. Do you have it all the time? Let's see how much you have, and let's figure out why, because it could be something totally different, not in you, but diabetes and high blood pressure, essential or idiopathic hypertension, are probably the two most common causes in North America of protein in the urine, totally unrelated to your scleroderma. Question back here?
Yeah, you said that the renal crisis is more prevalent in people with early diffuse. I guess kind of when are you out of that?
Right, so the danger zone is hard to say, but in the first 3 to 5 years, if you hadn't had kidney crisis, frankly, in general, you're not going to get it unless if your scleroderma wakes up weirdly and takes off at a point down the road. However, if you have had kidney crisis, you have a high risk of recurrence. So the people with scleroderma renal crisis, true bill, are given an ACE inhibitor, angiotensin blocker inhibitor, the most common Capitan or Captopril here, or enalapril, Vasotec. They're the two most common ones, indefinitely to prevent recurrence. But that pill, that drug class, doesn't prevent the first attack and might have us not detect it on time. So usually it's not the limited, it's the early diffuse, rapidly progressive skin involvement, more common in men than women, renal crisis, even though scleroderma is like 8 to 2 of women to men. So early diffuse man, or any early diffuse, I get them to do home blood pressure monitoring. And eventually, never happens, boom, I think you're out of the woods because everything else is settling down, as a for instance, or it's not going crazy, or the inflammation's down, skin score's improving. But to happen de novo at year 5 or 7 would be bizarre. Like, have I seen it? Yes, but usually the patient's scleroderma's woken up, we gave them steroids or something like that, or they got sick again with who knows what, some evil humor of an infection made their skin take off. So I've seen it rarely down the road without it being at the beginning. So it's usually early, first, couple years.
Thank you.
Yep.
So what specialist would diagnose the muscle involvement, the muscle pain? I mean, after the electrical test and all that, where do you go to next?
Right, so asking about the muscle involvement, who would diagnose it and where do you go to next? So most myopathy and myositis is painless. So many people have painful muscles and joints and tendons, because think of how everything's on contractures. Even if you have hand contractures, you start using the rest of your limbs a little bit differently, right? And if your skin's super tight, you can hurt deep down below the skin, not just on the skin. So that's different. So myopathy is usually diagnosed 2 ways. People have a high blood test, CK. That's your when you go to the emergency room and you think you're having a heart attack, they do a CK and tropes. So the muscle enzyme or creatine phosphokinase. Or someone presents weak, and not weak because you're tired with low blood or anemia. Weak meaning I can't get out of a chair anymore. Doctor, I used to get out of a chair last year. These chairs are too low. I have to push myself, or I have to roll out of bed, or I can't get into the van. I can't lift my leg up on the driver's side or the passenger side. I go, uh-oh. I'll do a power exam, I'll do the muscle enzyme blood test. I usually will do the nerve conduction studies, which is the muscle testing with the electrodes. I usually don't do an MRI unless if I need one to see where to guide a muscle biopsy, because if I have the answer before a muscle biopsy, okay, it looks like it's a myopathy that's infiltrative but not inflammatory. Okay, let's give you muscle fitness. It looks like it could be inflammatory. Let's do a biopsy so I can treat it. So as a rheumatologist, we treat dermatomyositis, polymyositis, but some specialists or some rheumatologists might say, oh, it's too uncommon for me, I'm not sure what to do. Often a neurologist, rarely physical med rehab, so rehab specialists can help to diagnose it, but often they're not the treaters, but it might vary per region and state and things. So rheumatologists know all about inflammatory myositis because it's an autoimmune thing, but they don't know to recognize it necessarily in scleroderma. And then weight loss, high muscle enzyme. Sometimes you have a really low muscle enzyme because you got no muscle left, and then it's tougher to make a diagnosis. So that's who would figure it out, but muscle pain common, joint pain common, overall pain. The usual patient coming into my clinic, and this shocks me until we did research on it, pain is 4 out of 10 for the usual scleroderma patient. And for different reasons, gut, calcinosis, ulcers, Raynaud's, lots of different reasons, tendons, muscles, skin. But the usual patient means 4 out of 10, which means most people with scleroderma have pain. 4 out of 10 is pretty high. That's the same as rheumatoid arthritis walking in the door. So it's pain's common, and I think we underdiagnose it and undertreat it, under ascertainment, because there's some treatments that you wouldn't even think of that might be helpful. Physical modalities, even sometimes medicinal cannabis, so that's the medical marijuana, sometimes helps people with pain. Lyrica or pregabalin, so gabapentin, Neurontin, those sorts of drugs. Sometimes the antidepressants help pain. Celexa, which is called duloxetine as well. So there's lots of things we can do to help. Anti-inflammatories if it's joint pain. Calcinosis, drain the darn thing if you can, if it's leaking, because that's really inflamed. Sometimes even corticosteroids are on it or around it. So different things can help. So that's just like muscles hurting, lots of reasons, so you got to figure out the reason. Any other questions? Okay, you've been a really great audience. I'll stick around if you have anything offline, and thank you for volunteering your answers, and enjoy the rest of the conference.